This is Module 4, and we're going to be talking about phlebotomy. We're also going to do phlebotomy in lab. This is going to cover two modules, so you'll have plenty of time to study. All MLTs and MTs have to learn how to do phlebotomy. We're kind of like a backup to the phlebotomist. When they get busy or they can't stick somebody, they can't get blood from them, then sometimes we have to help out. If you were an MLT in a doctor's office, you may have to do phlebotomy on an everyday basis. Most hospitals, the techs don't have to stick, but there are a few that the techs stick every day. It just basically depends on where you work. Okay, a phlebotomist is the person from the lab that patients see. They're usually who talks to the patient. They're the visible person. Usually when we get rated or the patients do surveys on the lab, that's usually what they're going by, is how they were treated and how they were, how their venipuncture went when they were getting stuck. So it's usually the phlebotomist. So the phlebotomists play an important role between the lab and the patient. They must have good bedside manner and guest relations. They need to be friendly, since they're the person from the person from the lab that a lot of people see. Even though they need to learn how to stick and how to do phlebotomy well, they also need to have a good personality, a good attitude, good communication. They need to treat patients like they want to be treated, and patient relations is the most important thing for a phlebotomist because they represent the lab, and they're the only representative that we have going outside the lab. Traits that a patient needs to see. The phlebotomist cares, they're friendly, cheerful, honest, professional, respectful, dependable, competent, and have a positive body language. Face-to-face verbal exchange, that's talking back and forth, is the most effective form of communication. I'm sure you know that. Talking face-to-face is things are expressed like they are meant to be expressed if you're talking to somebody face-to-face. The tone in a person's voice will speak their attitude, but 80% of the messages are nonverbal, like how you treat them. You can be verbally nice, but if you're jerking their arm around and, not being careful with them, then that speaks a lot. Body hygiene, attire, your hair, posture, jewelry must be professional. Look the patients directly in the eye. Touching is therapeutic for patients, or it is for most people. If a patient is not talking and they're able to talk, then it could mean that there is a problem. Also, if you go to a patient's room and they refuse to be stuck, then you have to request that. Now, when I was a phlebotomist, I just didn't easily give up. I would say, if I went into a room and they said, I don't want you to stick me, I would say, well, the doctor has ordered this test, and I would tell him what it was, and he needs to check this, or I would say, well, I need to go talk to your nurse because your doctor's ordered it, and most of the time they would consent. But just so you know, if they don't consent, eventually don't stick them because it can be treated as an assault. It is ultimately up to them. We can't make anybody get stuck. Telephone manners. When you're on the phone, whether you're a phlebotomist or a tech, you need to answer with your name and your department. Speak where people can understand you. Be pleasant. Find the answers, or tell them you'll call them back if you don't know the answers. When you go into a patient's room, you should always knock before you go in. A lot of times you may not even hear them come in, but hear them say come in. But if you knock, then give them just a few seconds and then go on in. Introduce yourself. Introduce yourself. You say, I am Dawn and I'm from the lab and I need to draw your blood. You tell them what you're going to do. You don't just come in and assume that they realize what you're doing there. You ask the patient for their full name. Identifying the patient is the most important part of a phlebotomist's job. You ask the patients for their name, though. You don't say, are you Jane Doe? You say, what is your name? Or tell me your name and your date of birth. And then when they're telling you, you check their wristband. The wristband should be on the patient's body, and I don't think that this is much as an issue as it used to be, but sometimes in the past, the patients, or maybe nursing did it, I'm not sure, the wristbands would be taped to the patient's bed, so it should not be off of the patient. If there's a patient unconscious, then he can be identified by the wristband and also nursing staff. You explain what you're going to do and make sure that you have consent. Patient's Bill of Rights. These are rights that are set up by the American Hospital Association, and they say that we need to be confidential, we need to treat them fairly, like you want to be treated. You don't tell their information, you don't talk about their diagnosis, their treatment, their bills, you don't even say that you stuck so-and-so today. Safety and legal control. You make sure that you have consent when you're going to do phlebotomies. Specimens. A good specimen is the basis of every test. If we don't have a good specimen, our test may not be accurate. Every MLT is a phlebotomist, so don't feel like that just because you're a tech, you're through with phlebotomy. You may have to stick again after you get through with school, but every MLT has to learn how to do it. Bad specimens can result in inaccurate results. The three most important things to remember in phlebotomy is patient or specimen identification. You ask the patients for their name, you look at their wristband, and you label their specimen correctly. Safety, you always be careful with the needles, you make sure that you dispose of them properly, and also patient relations. You want to treat them with respect and care and like you would want to be treated. Okay, types of specimens. Blood, body fluids, swabs, and tissues are the main parts. The reason that these are all in here is because not only do phlebotomists collect the blood, but they receive all these specimens in the lab. Blood is the most common specimen, and it's usually venous from a vein. That's what the phlebotomists usually stick. Arterial The radial in your wrist is where arterial is usually collected, or the brachial is the second choice. Usually these are collected by respiratory therapy or a doctor. A long time ago, phlebotomists were trained how to do arterial sticks, but not anymore. And capillaries are skin punctures, like a finger stick or a heel stick. We get body fluids into the lab. The most common is urine in a container with a closed lid, and they should all be in specimen bags. We get spinal fluid, synovial fluid, which is joint fluid, peritoneal, which is in the abdominal cavity, pericardium, which is around the heart, and pleural, which is around the lung. Sometimes we get just a little bit of fluid, like in a syringe or in a urine container, and then sometimes we get like 2 liters of fluid, depending on the patient, of course. The swabs, we get swabs. They look like just like a Q-tip. They're for the throat, the genital wounds, and environmental, and these are mainly for cultures. Biopsies, we get all kinds of biopsies from anywhere in the body, and the biopsies tend to go to cytology and pathology, but we do culture some biopsies sometimes, and we also culture hair, skin, and nails. Okay, factors to consider before phlebotomy. The basal state factors. Basal state is the resting condition. How is the patient when they're resting? Factors that affect the basal state is their diet. A lot of times we do the specimens, especially for lipids, proteins, and glucose, after the patient has been fasting for 12 hours. We want them to be fasting and have not eaten anything, so that those results will be accurate. Diurnal rhythms are daily fluctuations of mainly hormones. There are certain tests that are higher at a certain time of the day in our bodies, like cortisol. Cortisol is supposed to be higher in the morning. Posture can affect the protein. Stress can affect the cell counts. So the best specimen is when the body has rested, and the specimen is done early in the morning after 12 hours of fasting. Okay, specimen priority. We uh, we label and designate certain specimens as stat, urgent, or routine most of the time. Stat, that stands for short turnaround time, and that means that we're going to do that specimen right away. It's at the top of the list. So everything that's from the ER is always stat. And then we may have like something from the OR or recovery that's stat. And then sometimes if something's going on with the patient in ICU or even on the floor, we may have a stat from those areas. But those are always done right away, first before everything else. Then we have ones that some hospitals call them ASAP, some call them now, and some call them urgent. These are not as important as the stat ones, but they're the next on the list. They need it as soon as we can get it. Then there's time specimens. The time specimens have to be done at a certain time. Like when we check medication levels, they need to be drawn at a certain time after nursing has given the patient the medicine. When we're checking glucose levels in a glucose tolerance test, we check them after an hour of the patient drinking the glucola. So they have a certain time that they have to be drawn for the test to be right. And then there's routine, random, that are done that day. So we don't, it's not like we let those sit, but we make sure that the stats and the urgents are done, right away. And we do the routines after we've done those. Okay, whenever you go to stick, you need to pay attention to what you're doing. Look at the patient's arms. Make sure that you pick a good place. You don't want to do any that has bad scars or burns, and you can tell that something has happened there. They may have veins that you can't get to. If you've got a patient who's had a mastectomy, you're not supposed to stick the patient on that side. Now, with a double mastectomy, and a lot of patients are having double mastectomies now, it's really not the mastectomy, it's the lymph nodes. When my mom had breast cancer and she had a double mastectomy, but she only had the lymph nodes taken out of the right side. So the left side was okay for them to stick. So that's what they did. So most of the time, the patient knows. The patient will say, "You've got to stick me over here because, whatever." So just ask the patient. Joint replacement, if they've had a hip replacement or whatever, that side is decreased in vascular and lymphatic circulation. So there can be a lot of fluid buildup if you stick there. So if you know that they've had those things, then you don't need to stick them on that side. There may be a sign in the room, if it's a patient in a room, that says, that'll say only stick in the right arm, so that everybody knows. Sometimes we have patients that have severe edema, and edema is fluid buildup, and you can tell that they're swollen. You're not supposed to stick in these areas. When a patient has an IV, and it has saline or anything running through it, you can't stick above that IV. You may stick below. If you need to stick above it, you have to ask the nurse to turn off the IV for at least 5 minutes. You stick them and you document that you've done so, and usually that's okay. So if a patient has an IV, try to stick the other arm. Sometimes we have patients that have 2 IVs, so we just have to get the nurse to turn it off. Arteriosclerotic veins, these are veins that have buildup with plaque in them, and they're kind of hard. So you've got to anchor the vein down so that you can get in it. Okay, the easiest place to stick in the patient is in their arm, in the elbow. The veins are close to the skin. They're usually bigger than other places. And I've tried to find this. I hope you can read this. The antecubital area is this part in the elbow. The antecubital fossa is the medial cubital cephalic vein. This is on the thumb side of the vein. The basilic is the pinky side. The ulnar and the radial veins are on the other side. The dorsal hand veins can be used. There's a picture in your notes that you can read better. But basically, any of those veins in the antecubital area on this side, the other side of the elbow, is where we stick. The best veins are there. It hurts less, and it's just the easiest place to stick the patients. Okay, this is an example of the needle, and needles have gauges. So the gauge tells the size of the lumen. So the bigger the number, the bigger the needle. Okay, so it's measuring the inside of the lumen, which is the inside of the needle. So an 18 is bigger than a 24. An 18 gauge phlebotomists usually don't use. This is for giving blood. 20 to 21 gauges are used for good normal veins. 23, 24 for small fragile veins, children or babies. The butterflies usually have 23, but you can get them where they have 21 and 24 as well. So the lumen is the hole inside of the needle. This is the bevel. The needle is kind of cut off at a slant. It's not straight, you know. This is the shaft, and then this is the hub up here. Okay, volume. Before you stick, you need to make sure you know what tubes you need to get and how much you need to get in each of those tubes. Every test has a certain volume that we need in order to do the test, and you need to make sure that you get enough. So the specimen tube sizes are these are the most common. There's a 3 milliliter. These are called pediatric tubes because we use them for kids. Then there's 5 milliliters, 7 milliliters, and 10 milliliters. So the most common are the 7 mLs, I would say. The amount of blood drawn is equal to the test volume requirement times 2, since half of the specimen will be blood and half of the specimen will be serum. And I think there's a picture of that somewhere. So this is what the blood looks like when you first stick it, and then when you first stick the patient and put it in there. So when you spin it down, the red cells are going to go down here, and the plasma is going to be up at the top. So that's why it says you should have 2 times the amount of what you need. Okay, for example, a hepatitis panel needs 3.5 milliliters of serum. So we need a 7 ml because we need to make sure that we have enough. 3.5 times 2 is 7. Okay, some tests have special requirements to them, and you need to know these. Specimens like a blood gas or ammonia, those are the most common. Complement and lactic acid have to be put on ice right after you draw them. So most of the time, a phlebotomist or respiratory therapy will take a cup of ice with them, or a specimen bag with ice in it, and get the ice to go straight to the patient's room, put it on the ice, and then bring it straight to the lab. Whenever we this second one, whenever we get the specimens that are in these tubes, we centrifuge them down. Well, not all of them, but some of them like a CBC, we use it like this. We mix it up and we use it like this. For chemistry testing, we centrifuge it down, and the plasma or serum is on the top, and we use this part for testing. Well, some of the testing that's not done right away, we take this plasma or serum off and we put it in the refrigerator or in the freezer. So B12 and folate which are vitamins, need to be frozen. So they have to be, the serum or the plasma has to be taken off the red cells and immediately put in the freezer at less than 0 degrees Celsius. Dry ice can be used if the specimen needs to be froze. Light, bilirubin and keratin are broken down by light. So what we do if we have bilirubin, they make these brown tubes that we put amniotic fluid in. Usually what we do when we're just checking for bilirubin in the serum or plasma is just we go ahead and run it. We don't let it sit, because the light can break it down. The time, the ones that are ASAP need to be done right away. Enzymes, those end in ASE, blood counts, and glucose, because these can break down. We have a 1 hour limit on most tests in the lab in chemistry and hematology. From the time that we get it until the time that the results are released, we have an hour. Okay, the tube additives. So in this picture are examples of most of the tubes that we use in the lab, and they have different color tops. So the color tops tells us what's in them. Okay, if they clot, I'm trying to think of how I should explain this. In our blood, we have platelets, clotting factors, and fibrinogen and calcium, and all of these things help us to clot. Some of these tests we don't want to clot, like the one that I was saying, we use it just like this. We don't want this one to clot. We don't want it to clot. And then some we do want to clot. So most of these have anticoagulants. That means it's against clotting. So we don't want it to clot. So most of these tubes have anticoagulants in them. And the anticoagulant will keep one of these things from allowing the clot to form. The colored tops tells us what type of anticoagulant are in there. Some of them have liquid, and you can see the little bit of liquid in the bottom of the tube. Some have powder in them. Some look like that they've been sprayed. The inside of the tube has been sprayed with the anticoagulant. They all have a vacuum. The vacuum, when you stick the patient, it helps to suck the blood out of the patient. They have expiration dates, the additive and the vacuum. Sometimes we'll have tubes that blood won't come out of the patient, and that's usually because the vacuum doesn't work anymore and it's expired, because we get a lot of tubes from the hospitals. Okay. Coagulant additives. Now, these red tops, you see this red top right here? This red top, we want these to clot. We want all the red tops to clot. So a plain glass tube, it usually is a red top, it clots on its own. It clots naturally. Fibrinogen is the primary blood coagulation factor. Some of the tubes have clot activators in them, and they help the blood to clot faster, so we can go ahead and do the test. And I think this red top has clot activator in it. Plain red tubes have no additives. The glass is made of silicone. Some red tubes are red, black, or gold, and they have coagulants in them, and then some don't. You have to look on the label. When the blood is in a red, gold, or black tube, we centrifuge it. The liquid part of the blood is called serum. The serum does not have fibrinogen since it was used up in the clotting process. And these tubes that require serum are used in chemistry and serology, and plain red tubes are also used in blood bank. So let me read over this. The anticoagulant tubes have anticoagulants in them, and they keep the blood from clotting, so they never clot unless they're not mixed properly. Whenever the specimen is collected, they have to be mixed. You centrifuge down the red cells, and this part up here has the fibrinogen in it, and it's called plasma. Most are chelators that bind to ions like calcium that keep it from clotting. Okay, now let me explain this a little bit. Serum versus plasma. Okay, most of the time serum comes from a red top tube. The plasma comes from mainly greens. That's the ones that we used most often. Okay, so this is a plasma tube. So this is one that has anticoagulant in it. So if we put the blood in here, it has an anticoagulant in it. The blood does not clot, so we centrifuge it down. This top part is called plasma, and it has fibrinogen in it. Okay, this is like what happens in a red top. In the red top, the blood clots. We centrifuge it down. The fibrinogen is used up in the clot, so there's no fibrinogen here. So this is called serum. So the only difference between the tubes is that fibrinogen is in plasma and fibrinogen is not in serum. The fibrinogen is used in the clot. So this is one that there is no clot and there's fibrinogen, and there's a clot and fibrinogen's in the clot. So there's no fibrinogen up here. Some tests require this type of testing, and some tests require clotted tubes. Okay, so the types of anticoagulants, you need to know all of these. The pink tops and purple tops, they have EDTA in them, and that stands for ethylene diamine tetraacetic acid, or acetate. And these are purple and pinks, and they bind calcium. So they bind the calcium up. The blood can't clot because the calcium's not there. So these are mixed. We don't centrifuge these down where we get this plasma and serum. We don't centrifuge the ones that go to hematology. We don't centrifuge those down. For the most part, these tests go to the hematology department, and in some hospitals, the pink goes to blood bank. This does a CBC panel, which includes the hematocrit, hemoglobin, platelet, and white cells. So what you need to know is the purple and the pink have EDTA in them, and they bind calcium, and what department we send them to. The sodium citrate is a blue top tube. It binds calcium. It's used in heme coag, and it's used to do the PT, PTT, and fibrinogen, and these are clotting time tests. And this plasma, we centrifuge these down and we get plasma, and it's called citrate plasma. Okay, the potassium oxalate is a gray top. It also binds calcium. It's used in chemistry for glucose and lactic acid testing, and the plasma is called oxalated plasma. The SPS or ACD tube is the yellow top tube. It also binds calcium. It's used to draw blood cultures and they go to the micro department. However, these are not highly recommended for blood cultures, but that's what they are made for. The ACD is used to draw special blood bank tests, and that would go to blood bank. The heparin is a green top. It works by removing thrombin. You need to know this because it's different from the ones that bind calcium. So the heparinized tube removes the thrombin, which helps the blood to clot so it won't clot. And these go to chemistry. They do BMP panels, which is a basic metabolic panel. And in that test is sodium, potassium, chloride, glucose, kidney function test. Also, the green tops are used for TDMs, which are therapeutic drug monitoring. This is to do levels on medications like vancomycin, phenytoin. We do drug levels on different things. And also hormone tests like HCG for pregnancy. Okay, anti-glycolytic additives. After the blood is drawn, the red cells are in there, and they will metabolize the glucose in serum and in plasma, and this is called glycolysis. So there is an anticoagulant called sodium fluoride that has an anti-glycolytic in it, so it keeps the red cells from utilizing the glucose so that we'll get a more accurate result. And this is in a gray top tube. It has sodium fluoride in it, and it's used for a more accurate glucose test. If we use the green or the red to do glucose, and it's done right away, it's not a big issue. But if this is going to be sitting a while and it's not going to be done right away, then the sodium fluorides should be used. And this is taken to chemistry. Okay, then there's these tubes called SST tubes, and that's a serum separator. And they usually have a gel in them. Here's one right here. This is a gel that will separate. So you draw the specimen. When you centrifuge it down, this gel will go up here in between the red cells and the plasma. So the red cells will fall to the bottom, then there's a layer of gel, and then the plasma will be at the top. It's used to separate the plasma or serum from the red cells. It has a density, the gel has a density that's between the plasma and serum and the cell, so it will stop between the two to separate them. It's used in chemistry and serology, and it should never be used in blood bank. Okay, so here's supplies that you need for the venipuncture. Most places have a phlebotomy tray that's used, and we have some of these. It has vacuum tubes in it, different sizes, different colors, so you'll have what you need hopefully when you go to stick a patient. The tube shouldn't be used beyond the expiration date so that the anticoagulants work and the vacuum works and the test will be accurate. Usually alcohol is used as an antiseptic, and what's most often used is 70% isopropyl. Betadine or iodine can be used for blood cultures or alcohol levels, ETOH. the tourniquet is used. Usually we have a latex free tourniquet. It says latex strap tourniquet because we used to have all latex tourniquets, but now everybody has latex free tourniquets. Or a blood pressure cuff could be used if that's all you had. Needles, of course, you need the needles and you need the holders that go with them. You need gauze, butterfly needles, syringes, the needles that goes with those, transfer devices, Band-Aids. We also make sure that we have a pen to write things down with or to label our tube when we collect it. Okay, the order of draw. The purpose is to avoid contamination from one tube to the next. You've got to remember the order of draw. When you draw a sodium citrate tube, that's the blue top tube. Let me go back. That's this blue top tube. This is for PT and PTTs, and it has to be filled to the line. And this probably has a line like on the other side that we can't see, but it has to be filled all the way to the line. It has to be filled up, no exceptions. Well, if you're collecting a blue top tube with a butterfly, the vacuum will suck the air out of the tubing of the butterfly, and it won't allow you to fill the tube up all the way full. So what you got to do is, if you're collecting a blue top with a butterfly, you've got to use a discard tube. So what you do is just get a red or some other color tube and put a little bit of blood in it, and you're going to throw the blue top. In your notes, there is two different acronyms that you can use. There's an acronym on page 8 at the top. Becky loves real good lasagna. And this is a short one because it only has the ones that are most commonly used. The blood culture, the loves is for light blue, red, and then green, and then lavender. This is the order of draw for the most commonly used tubes. But at the bottom, the order of draw, which has more in it, the acronym is stop, light, red, stay put, green, light, go. So this helps you to remember the order, and you need to know both of these. Okay, types of phlebotomies. We do an evacuated tube with a vacutainer. I'll show you what this looks like. We have a butterfly. Most people know what a butterfly looks like, and they know what a syringe looks like. A lot of the facilities are getting away from using syringes because of safety reasons. It's a lot of needle sticks have been occurred from employees using syringes, so they're trying to get away from it. Butterflies or syringes are used for small fragile veins, or that's what they're supposed to be used for. And it allows for you to have a better control of the vacuum, and it's used for children and elderly, or babies and the elderly. Special procedures, the blood cultures. Blood cultures, we draw the patient's blood and we're looking to see if there's any bacteria in the bloodstream. So these are done stat. We don't clean their arm with alcohol. We clean it with iodine or betadine or chlorhexidine. And a lot of the facilities have something called ChlorPrep that's used to clean the arm. These will sterilize, not just clean like alcohol, but they will sterilize the skin so that none of the normal bacteria that lives on our skin will get into the bottle. If you don't clean the skin with these and you don't clean them properly, then some of the normal bacteria on the patient's skin can get into the bottle and make it look like they have bacteria in the blood when really they don't. It came from their skin normal flora. Okay, legal blood alcohols. This is usually called a ETOH. This is usually initiated by the highway patrol. Usually the physician will order an alcohol, and it doesn't have to have a chain of custody or anything. We just draw it and do it like we do any other test. But the highway patrol has to have a special one that has a special form, and you have to use betadine or iodine when you're checking alcohol. You don't want to wipe their skin with alcohol. And chain of custody is used to make sure that the specimen was given to the appropriate people, and it wasn't lost, and it didn't get into the wrong hands. Okay, other special procedures. VADs are vascular access devices, or indwelling catheters. These are caths like a portacath that are inserted by the doctor, usually in the operating room, and they're directly in a vein or an artery. Most of the time they're used to administer medications like especially chemo. But also, blood can be drawn from these. The RN has to do it though. So when we have a patient that has one, we ask the nurse, can they draw it? When it's drawn, she draws it with a syringe, and then 5 to 10 milliliters has to be thrown away, especially if they have fluids going through it. But even if they don't have fluids going through it, it needs to be thrown away just for the chance of contamination with little clots or anything. So they throw away a waste, and then they draw us a syringe, and we put it in the tubes, and then they flush the line to clean it out. So the types of these are a heparin lock, portacath, a Hickman cath, or an A-line. And all of these can be used to draw blood. Okay, phlebotomy complications. Every once in a while we do have patients that pass out. So that's definitely possible. It's caused by decreased oxygen to the brain. This is one of the reasons why we have those phlebotomy chairs. If we have a patient who is in the bed, it's not a big deal. But for outpatients, we have those chairs, and the arm locks. And the reason that the arm locks is so if they were to faint, they wouldn't fall on the floor. If you ever have an outpatient and you're able to lay them down, or you know that they're have fainted in the past, then you want to lay them down. Patients most likely to faint, teenage boys and pregnant women, but that's usually not all of them, obviously. Symptom of fainting is facial pallor. You know what people, they start to turn white looking. Sweating, slurred speech, and dizziness. They may not even tell you. I've had patients that didn't say a word, and then the next thing I knew they had fallen. If a patient faints, you take the needle out, you call for help, you lie them down. You can cool them down with a towel on their forehead or a fan. We have ammonia inhalants, or most lab has ammonia inhalants to wake them up. You can elevate their feet, or use a wheelchair if they're an outpatient so that they don't have to walk. Also, sometimes we can have excessive bleeding, especially if the patient's on blood thinner. Infection at the puncture site, which is rare. A hematoma, this is an example of a really bad hematoma. And this is where the patient bleeds under the skin. Pain, if there's a lot of pain, then usually they have the phlebotomist has accidentally punctured a tendon. Thrombosis, which would be a clot, and that's not very common as well. Petechiae. If you leave the tourniquet on too long, this is what petechiae looks like. And we don't want to cause the patients to have that. The tourniquet's supposed to stay on 1 minute and no longer. And also some patients become nauseous. Okay, failure to get blood. What can you do if you don't get any blood? If you're still in the vein, then you can change the tube, because every once in a while we get tubes where the vacuum doesn't work, and you can change the tube to make sure that that's not the problem. You can change the angle of the needle or the depth of the needle as well. If you have stuck the patient already, you can ask them, can you try again? But you never stick them more than twice. You go and get somebody else to stick them, preferably somebody that has more experience. Okay, hemolysis. This is hemolysis is when the red cells lyse, and it can cause the serum to be pink or red. This is what serum is supposed to look like, and this is a gel serum separator tube. So this is the clot, this is the gel, and this is the serum. So this is what it's supposed to look like, pretty and yellow. This has a little bit of hemolysis, and this has a little bit more, and this one has a lot. But we're not supposed to do tests on any of the tubes that have hemolysis. Okay, the causes for hemolysis. The needle's too small. The vacuum of the tube is too strong for a tiny vein. If you mix it too hard, a traumatic stick, like you couldn't get them and you were moving the needle around, overheating the specimen tube, forcing the blood into the tube with a syringe. You're not supposed to do that. When you put the syringe on the tube, you're supposed to let it freely go in there. Exposure to alcohol and scraping the skin with the scoop of a microtainer. And that's like when you're collecting with a finger stick or a heel stick, and the microtainer is a real small tube. Okay, specimens need to be recollected if they're not labeled right, if they're not labeled at all, if the specimens are hemolyzed, if it's supposed to be an anticoagulated tube and it has a clot in it, if it's a short draw, which means there's not enough specimen, and QNS means quantity not sufficient, especially for the blue top tube. Remember, it has to be drawn to the line. In your notes on the last page of 11, these are examples of what you need to study. You need to make sure that you know, and these are just examples, they're not all listed. You need to know the anticoagulants that bind calcium, the one that binds thrombin. You need to know what tubes are taken to what department as well. And we'll try to touch base on those in lab as well. Okay, that's phlebotomy. Let me know if you have any questions.